Good afternoon, everyone. I'm presenting the study on comparison of optic nerve head changes in patients with thyroid orbitopathy and age-matched normal individuals. The background of the study, thyroid eye disease affects 25 to 50% of patients with Graves' disease, and around 3 to 7% develop vision-threatening complications such as optic neuropathy. Optic nerve was evaluated clinically in terms of visual acuity, color vision, pupillary reaction, and visual field, and optical coherence tomography is a more reliable and reproducible tool for assessing the anatomy of the optic nerve. Retinal nerve fiber layer thickness has been proved to decrease in patients with thyroid eye disease who had no clinical sign of optic neuropathy, which indicated structural damage might occur earlier than functional impairment. The objective of the study was to analyze the optic nerve head and macular changes in patients with Graves' disease using OCT and to investigate the association of Graves' disease and intraocular pressure. It was a cross-sectional study for a period of 2 years in eyes of patients with Graves' disease, and 64 eyes of 32 patients were taken by based on a study by Guo et al. With 80% power and 95% confidence. The minimum sample size was 64. The inclusion criteria: patients included in the study were diagnosed with Graves' disease with no evidence of optic nerve compression clinically based on visual acuity, pupils, color vision, visual field assessment. And exclusion criteria were patients with significant cataract and media opacities with OCT scans of signal strength less than 5/10, conditions known to be associated with retinal nerve fiber layer abnormalities, glaucoma and other optic disc changes, and myopia of more than -3 diopters and hypermetropia of more than +3 diopters. 32 case and 32 controls underwent the following tests of best criteria: visual acuity, color vision, contrast sensitivity, refractive errors, intraocular pressure by appellation tonometry in straight gaze, 90D lens examination, fundus examination, HFA, optical coherence tomography for retinal nerve fiber and macular thickness, and clinical activity score in patients with thyroid eye disease. The statistical analysis was IBM SPSS version 26. The results based on the gender distribution, 37% were male and 63% were female in cases, and in the 32 eyes of controls, 44% of them were females and 56% of them were males. The age distribution cases, the mean age in cases was 43.5 years and the mean age in controls was 47 years, and the range was between 18 to 65 years of age. Functional optic nerve assessment, visual acuity in cases and controls was 0 by logMAR, and color vision and contrast sensitivity in cases and controls was normal, and the clinical activity score in cases was 1.12 with a standard deviation of 1.2. Hertel's exophthalmometry, there were 59% of them had a Hertel's exophthalmometry value of more than 21 millimeters and 41% had less than 21 millimeters. Coming to the retinal nerve fiber layer thickness, there was thinning in the retinal nerve fiber layer in the cases in the nasal and the temporal quadrants, and the values in the temporal quadrant were statistically significant. In the inner macular ring thickness, there was thinning in the inner macular ring thickness in the nasal and the superior quadrants in cases as compared to that of controls. And in the outer macular ring thickness, there was thinning in the all the quadrants in cases as compared to that of controls, and the thinning in the nasal and the superior quadrants was statistically significant. The mean intraocular pressure in case of cases was 19.5 mm of mercury with standard deviation of 2.51, and in controls was 18.84 with standard deviation of 2.83. Ocular hypertension, there were 10 eyes, that is 31% of them, who had intraocular pressure of more than 21 mm with no associated retinal nerve fiber layer changes or optic nerve head changes. Patients with thyroid ophthalmopathy were compared with age-matched normal individuals, and the mean intraocular pressure measured by appellation tonometry of cases was higher as compared to that of controls, and this difference in the IOP could have been caused by relatively increased intraorbital contents in the study group. Out of the 32 eyes, 19 eyes, that is 59%, had an exophthalmometry value of more than 21 millimeters, and out of these 19 eyes, 9 of them had an increased IOP of more than 21 millimeter measured by Goldman's appellation tonometry in straight gaze. Comparing the study to other studies, in a study by Sayan et al., the difference in the inferior RNFL values was found to be statistically significant, and a study by Ibrahim and Menoufe et al., there was no significant difference between the two groups. And in our study, there was a difference in the temporal quadrant, which was statistically significant. And coming to the inner and the outer macular ring thickness, in a study by Sayan et al., the thinning was observed in the inner and outer macular thickness in all the quadrants, and a study by Ibrahim and Menoufe et al., the inner and outer macular ring thickness was increased in cases compared to that of controls. And in our study, there was thinning in the superior and nasal quadrants in both the inner and the outer macular ring thickness. And coming to ocular hypertension and comparing our study to other studies, in a study by Kalman and Morut et al., Out of 482 samples, 4.8% had ocular hypertension, and a study by Cogoheim et al. Out of 500 eyes, 24% of them had ocular hypertension, and a study by Silva et al. 107 of them were studied, and 3.7 had ocular hypertension. In our study, out of 32 samples, 31% of them had ocular hypertension. In this study, it was found there was temporal nerve fiber layer thinning, superior nasal macular thinning as compared to the control group, and it was found that intraocular pressure was higher in patients with increased proptosis, and it is also found that in patients with Graves' disease, there is thinning in the RNFL and macular thickness. This indicates structural changes occur before functional changes or other clinical signs. These are my references. Thank you.
Okay. Are you combining together the thyroid disease with ocular hypertension, or two categories separate? How done the study?
32 samples were taken, sir, and out of them, the people who had an intraocular pressure of more than 21 millimeter was also studied.
What's the division? All patients have ocular hypertension?
Not all patients had ocular hypertension, sir. Only out of them, 59% of them had increased. So 31% of them had increased ocular hypertension.
Why you brought the ocular hypertension to thyroid also? Why?
Because increase in intraorbital contents can cause increased IOP, which can later cause glaucoma also. So then,
then what is your final conclusion?
That increased thyroid eye disease is associated with increase in intraocular pressure.
Okay, so you should do a glaucoma screening also.
Yes.
How do you make the diagnosis of thyroid ophthalmopathy in this case?
It can be based on clinical activity score based on all endocrinological and other immunological findings.
Any imaging? No.
Imaging CT, MRI can also do USG.
In your study?
In my study, I didn't do USG, sir, based on clinical activity score and also based on immunological and endocrinological findings.
Okay.